look for it there. These are the objectives as far as what we want to talk about. Talk about the concept of how spontaneous breathing, especially in the patient who's on APRV, which is really the crux of where I think this is all at. Who should be put on APRV, and then hopefully through this you'll be able to get an idea of, gee, what do I do now? How do I set them up? How do I make changes? How do I get them off? It's kind of the idea. So here's our little clinical simulation that we have. For those of you who have suffered through that exam, you know what I'm talking about. You're called to assess the 22-year-old female who's involved in a motor vehicle accident with chest wall injuries as well as internal abdominal injuries. You can see her tidal volume of 6 milliliters per kilogram, ARDS formatted, respiratory rate of backup of 14, breathing at a rate of 20, 60%, 5 a peep, and there are her blood gases. You can see that you have some hypoxemia there, but a respiratory alkalosis beyond that. And the question is, which of the following interventions would you choose? You being the participant here. And this is the option you have, and if you go ahead and just push one of the 6 buttons there, it'll kind of give us an idea of where as a group we are. On the back side, it does have a little serial number. It'll tell you what your number is. Doesn't really matter. I'm not taking a tally and saying, oh my goodness, that person answered this. Oh. I use this with my students, many of which are here or former students, and they will attest to the fact that I can go back and look, so it's a little bit scarier. All right, everybody got a chance? Let's go ahead and see where our votes are at. Then it looks like we're going to go primarily increasing the PEEP. There is no wrong answer here. Each of these interventions do make some sort of sense in the process, probably the least of which is increasing to 80%. If you have a PO2 that poorly on 60%, you probably have a profound enough shunt that it's not going to, it's going to be refractory oxygen therapy. Interestingly, nobody chose recruitment maneuver of 40 centimeters of water, 40 seconds. Really, that's institution specific. Some docs have really bought into it, and some have not. Hi-Fi is, again, an option that works. APRV, a few folks there. And obviously, none of the nurses chose. Is there any nurses here today? The prone position, that's where when you're on rounds and you automatically suggest putting somebody in prone position, and you just see the face of the nurse turns white because no one likes to put people in prone position. Going back in time, ARDS is not a new phenomenon. It was first described in the late 60s by Ashbaugh and Tom Petty. I'll give you the reference there if you ever want to go back and pull the article. It's quite interesting to go ahead and read. The thing to remember with ARDS is there's no lab tests, no radiology procedure specifically that's going to rule it in or rule it out. It's a clinically based decision that we end up doing, and it's basically these 4 facts. Acute onset. It's not something that the person was chronically in this condition. A PF ratio of less than 200, and this is the one I always yell at my students. How hard is it to calculate a PF ratio, especially when on 100%? It's pretty damn easy, okay? Less than 300 is considered acute lung injury. Less than 200 is one of the criteria for ARDS. Bilateral infiltrates on chest x-ray, that whiteout picture, a diffuse, what appears to be a diffuse atelectasis. In reality, if you look at a CT scan, that is not the case, and I'll talk more about that. And unlike a cardiogenic pulmonary edema, this pulmonary edema is not secondary to a cardiac origin. So any patient that has those 4 criterion, they're in ARDS. Now you'll always get the doc that goes, oh, well, he kind of looks like he might be going into ARDS. Does he have these things? He's there. No use kidding ourselves from that point onward. And if we're continuing to do conventional ventilation, when you have this, if you're continuing to use 10 cc's per kilo of ideal body weight, you're doing it wrong. And that's the bottom line where we need to address it. But that's the classic definition of ARDS and the one that the ARDS NET study utilized. So let me ask you, what % of patients with ARDS die of primary pulmonary causes? All right, let's go ahead and see what we got here. And it looks like we're kind of all over the board. And the answer is, I didn't put that answer up there. The answer is 10 to 15%. Very, very few patients with ARDS die of respiratory problems. They die of multi-organ failure. They die of sepsis. They die of heart failure. They die of bowel infarctions. They die of all kind of other stuff, renal disease. What causes those things to happen is the fact that we ventilate improperly. We overdistend the lung. We end up causing damage. All kind of chemical mediators like cytokines and tissue necrosis factors and all these other things get circulated around to the rest of the body, and they develop multi-organ failure. So who's at fault for ARDS worsening and the person dying? We are. Who's the best person to recognize it? We are. So that's what hopefully we'll end up doing with this. If you take a look at all those things we talked about, recruitment maneuvers, and you talk about prone positioning, and you talk about APRV and high-frequency ventilation, within ARDS, none of them have had the randomized controlled study saying it's better than conventional ventilation, not even pressure control. Okay? Well, part of that is, I think, that first statement. We wait. Well, they got a PO2 of 45 on 100% and 47 a PEEP, and let's try APRV. No, don't bother. You're ventilating a brick by that point in time, and you're not going to have success with it. You got to intervene early. All of them will work to some extent if we end up doing it. The other thing is, I think we're going to find out we're not there yet. I think 10 years from now we'll have a better idea. I do believe that the ARDS is not, it's a syndrome, but it's a syndrome caused from multiple factors. And ARDS that's caused by sepsis probably is treated differently than ARDS that is caused by trauma. So where APRV may work great in trauma patients, and it does, it may not work as good in septic patients. Or recruitment maneuvers may work good in pneumonias, but they may not work good in other types. So I don't think we're quite there yet, but 10 years from now we may end up saying, you know what, this is the cause of the ARDS, this is the route we're going to end up taking to treat it. Fascinating study by Smith and Pell, and if you ever have a desire to want to get a good chuckle, the British Medical Journal in their December issue always publishes articles that are a little bit tongue-in-cheek, and this is one of them. It's called Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenge, a Systemic Review of Randomized Controlled Trials. They looked to see if patients using, or people using parachutes had less damage from gravitational impact than folks who did not use a parachute. Amazingly, they found that there was no randomized controlled trials proving parachutes work. Tongue-in-cheek. Of course not. Common sense will tell you. And that's another thing that you got to get into folks' head. And docs will say, well, this doesn't work. There's no proof that it works. There's no proof that it doesn't, and the proof that is there says it's as good as anything else we have. And common sense, when we go through the explanation of what it is and how it works, common sense says it might be a better alternative in some cases. It's not the panacea by any stretch, but it is another option we have. I think that's where we sell ourselves short. So part one, or pearl number one, is do something. Don't sit on these patients for prolonged periods of time. This is all based upon a concept that was described by a pulmonary physiologist named Lachman back in the early 90s. And the open lung concept is get the lung open and keep it open. Well, that's a pretty simplistic concept, but that is the essence of what you need to do. Get it open, but don't overdistend it. Get it open, but don't push so much volume into it that you end up doing damage to that lung, because that's the thing that's going to cause that high mortality. And don't allow it to collapse back down once you get it open. Once you get it open, there's no more snapping shut. You need to keep it open in the process. There is something called ventilator-induced lung injury, VILI. Another individual said, well, no, it's really physician-induced lung injury. I like to think of it as, how about we do a therapist-implemented strategic improvement, a little TIFI. So we're going to try to get some other concept. This concept of overdistension is well documented. This is basically, if you look at the ARDS net study, what they ended up looking at was a smaller tidal volume, generating 6 to 7 cc per kilogram, had a better improvement than those had at 10 to 12. I think you've all seen that study. A couple of caveats to that study. If you look at the New England Journal's title, it said a smaller tidal volume strategy was an improvement. Really what it was a smaller plateau pressure. You had patients who had 6 to 7 cc's per kilo that still died, and you had persons with 10 to 12 cc's per kilo that still lived. So it wasn't necessarily the tidal volume, it was the plateau pressure that was generated with that. And it's that excessive volumes or excessive pressures, probably is more and more along the line, that leads to those chemical inflammatory mediators being released and the multi-organ failure happening. And the concept was, let's protect the lung by not banging it, by not putting, 800 cc's in just because that person said we needed that mathematically they should have 800 cc's. The other concept is don't let it, this repetitive open and closing, that shearing effect that you end up seeing. ARDS is unique in that it has a very gravity-dependent component to it. And however the patient is lying, the gravity-dependent portions of it are the poorest ventilated areas. You turn them on their side, you turn them on their stomach, you're going to have still gravity dependency being a huge component of it. And what you end up having is that attempt then when you ventilate to try and get that alveoli open, it quickly will close itself back down. And that mechanism also, beside collapsing that alveoli, alveoli which are peripheral to it are also pulled in with it and collapsed with it. So it's not just a sole unit that is damaged, it's a whole area of lung. I don't know if you've seen this video or not, but we'll go ahead and watch it again because it's good. This is a rat lung or some kind of lung, I don't know, they got. And this is on ZEEP. Okay, so they inflate it, positive pressure breath, deflate it back down. Then they're going to go to 10 centimeters of PEEP. And they're going to ventilate from that point. Notice how there's not that de-recruitment that you end up happening. And notice how you're inflating all areas of the lung. Now, granted, this is a little bit invalid in the sense that it's just a small unit here. But we're ventilating now with a fully inflated lung. Now we're going to go back to ZEEP. And that's how quick it happens. That's how quick de-recruitment occurs. If you don't take anything else home with you, take home the fact that when we go ahead and we disconnect that ventilator patient for any reason, including transporting them, you de-recruit. Most of the ventilators now have the mechanism of having a battery-powered source to power the ventilator while you're transporting it. Don't disconnect them, because that's going to happen. And it's I think a more common problem in the ICU than we think about. So these are some of our open lung concepts that we end up having. High frequency oscillation, where we oscillate around a mean airway pressure with small movements of gas in and out of the lung. Recruitment maneuvers, of which the open lung tool on the servo eye is a classic example of how it can be used. We talked about prone positioning. The prone positioning works very well when you have a left lung that seems to be a primarily involvement, because what it does is it pulls the heart anterior or downward and allows that posterior portion of the lung to be able to use it. Certainly PEEP is still of value. I mean, it's not like we're throwing that out entirely, but I'm going to focus on the last one, airway pressure release ventilation. But I think, again, all of these things all have purposes, just not sure where. The concept of mean airway pressure is what we're talking with. So here I have an inspiratory time of 1 second, generating a mean airway pressure of 9. And again, mean airway pressure is everything that is underneath that curve. If I lengthen the inspiratory time, I increase the mean airway pressure and thereby increasing the PO2. And the same is true if I go further to the next level. I have more space under that curve. I have an increase in mean airway pressure and increase in PO2. The goal of all of these is to increase the mean airway pressure. If I can keep the mean airway pressure open, I allow that atelectatic area to be re-expanded. Okay? Think back when you learned incentive spirometry, right? You had an atelectatic patient, you want to give him an incentive spirometry. What did we do? We went into the room, we said, hi, Mrs. Jones, how you doing? Take a deep breath, deep, deep. Now hold it. Okay, go ahead now. Exhale. It was the hold it component that was the benefit. Because we got them open and we held them open to reestablish that alveoli. If you want to get a great way of explaining APRV to docs, there it is. Tell them it's just like incentive spirometry, because we're basically holding the lung open and allowing that alveoli, which has become destabilized, to become restabilized. What it is a form of augmented pressure ventilation. So it is pressure control, just in a little bit of a twist, because it allows unrestricted spontaneous breathing at that elevated pressure. It's a two-pressure setting, so we have a high pressure and a low pressure, and that low pressure, that transition to the low pressure, is so short that there's not time to take a spontaneous breath down there. There was a recent article in Respiratory Care where they're talking about allowing spontaneous ventilations at the baseline pressure. That's not APRV. Even though the ventilator may say it is, it's not. By definition, you can't take a breath down at that lower level. Call it CPAP with a release. It's spontaneous breathing at an elevated baseline pressure where periodically we dump that breath out and go to a lower level. It's got similarities to some other pressure-based ventilations, pressure support, pressure control, kind of really like pressure control with inverse ratios. Remember back to those days. It's certainly not BiPAP where you're going up and down with each breath. It's also not new. It's been around since the late 80s. Okay? Many of you may not have been born at that point yet. So, first described in 1987 by John Downs and Christine Schock. So it's been around. It suffers from what I call acute iatrogenic terminology disorder. Every ventilator manufacturer calls it a little bit something different. And every article that is wrote describes it a little bit different. In fact, the term BIPAP, BPAP, as it's called in Europe, is what we call APRV. Oh, let's really screw this process up now. Okay, so you got to be careful when you're reading stuff that you understand what's going on. And it is a source of controversy. I remember being at an ARC meeting, and one of the docs who was there was saying, well, it doesn't really work. There's no proof that it does anything, blah, 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 blah. And then the next speaker happened to be a speaker talking about the H-flu epidemic, the influenza epidemic. And at that hospital, which was the same hospital the previous doc worked at, guess what they were using to treat patients who had flu? Oh, by God, it was APRV, and they were getting them off. So sometimes I think the controversy is there just to make a controversy in the process. But instead of doing this, inflating their lungs, letting them deflate, why not do this? Leave them inflated all the time and add some of those. So I have spontaneous ventilations going on at an elevated baseline pressure, and I quickly release it and get right back up there. That's the beauty of it. So why is spontaneous breathing so important? Well, spontaneous ventilation improves distribution of that tidal volume to areas that are gravity dependent. Okay? It may also improve ventilation through some of these alternate pathways. And the pain is, oh my God, going back, did we ever learn this? I think somewhere along the line, the canals of Lambert, pores of Kahn. Actually going through and doing research for this, I discovered a third one, the channels of Martin. Huh? But what you end up getting is a better spontaneous ventilation, a better inflation of lung in the dependent area. Okay? So what you end up doing then is you end up putting more volume to areas that have poor VQ relationship. Take a look at this first one here. Here's my tidal volume going in, and most of it's going to the gravity-dependent regions. Less is going to this area. When I mechanically ventilate somebody, I preferentially put it to the non-dependent regions, which is why it's probably not working in ARDS, because that non-dependent region is the area that's collapsed. What you also do in the process, oh my God, west zone of the lung. I thought I forgot about that when I graduated. Those areas where you end up having ventilation going with no perfusion or limited perfusion is going to end up being dead space regions. You have increased VDVT whenever you have a patient in ARDS because most of the perfusion is going to the bases. Most of the ventilation I just showed just going to the non-gravity dependent regions. You get a VQ mismatch. Plus, you also have perfusion going to poorly ventilated areas. I got a big shunt. I got a mess going on. In fact, there was a great research, there was a great study done that showed that in ARDS, if you are measuring your VDVTs, well, that would require a capnograph, and God forbid that would ever be utilized, pulled out of the closet. But if you were measuring VDVTs, patients who have higher VDVTs in the first 48 hours have a poorer mortality. Probably because this phenomenon is going on. So being aggressive and being able to get to a point where we're pushing ventilation and perfusion together makes sense. Here's a look at looking at CPAP, looking at pressure control, and looking at APRV. This is the patient who is, this is the ventral portion or the non-gravity dependent portion and the gravity dependent portion. CPAP, you see with spontaneous breathing, more ventilation going here. This is actually the best of all of them because you got a good mismatch, a good match involved. The pressure control, where are we putting the volume? It's all going to the non-gravity dependent portions, creating dead space. Kind of worsening our problems. Lots of stuff on this. This one author, by the way, if you ever do a search on him, Christian Putenson, he's out of Germany. He's probably done the most research on it. There was actually a study that was published latter part of last year that looked at trends in use of APRV, and they kind of showed on a map where it was all done. And like Germany was this big black color where it was this concentrated, and a little bit in pockets in the U.S. and no one else used it. So I'm not sure if that's good or bad. But what about hemodynamics? You got this patient on a high pressure. Isn't that bad? Aren't you harming the patient hemodynamically? No, actually, they have better cardiac output, better oxygen delivery, better use of that oxygen as far as myocardial oxygen demand, and better perfusion to the other areas of the body. I'm not seeing why that's a bad thing to have them spontaneously breathing. Increased venous return, increased preload, increased cardiac output. This is the argument I always get, but they're really, really sick. I need to paralyze them. I can't let them spontaneously breathe. Well, interesting thing is patients who are on this require less paralytics. And paralytics can be a problem. We're now starting to see more and more documentation that patients who are on prolonged use of paralytics end up having post-paralytic neuropathies and having difficulty long-term wise. So maybe it's not so great to paralyze them all the time. Certainly they could probably get by with a little bit less sedation, and because of the improved cardiac output, I don't have to worry about vasopressors as much. So who do we use it for? Anyone who has acute lung injury, ARDS, or lots of atelectasis, which in a way is kind of what the definition of ARDS is. I always used to tell people, and I should disclose that I did work for Puritan Bennett for 6 years, so I did a lot of training on this at that point in time. But I used to say anyone who has refractory hypoxemia that's caused by a pulmonary pathology, and then that's reversible. And that's the important part, is reversible. Okay? If you got someone who's got, oat cell CA and their PO2 is 40, it's probably not going to do much good. Okay? It's got to be a reversible process. Jim Henson, right, came in with a bacterial pneumonia, was dead 24 hours later. Very well may have helped him in that. Who don't we use it on? Patients who you have a need to hyperventilate, at least in the interim, because of cerebral edema and high ICPs, probably are not the best people for it. Patients who you need a lot of sedation for or paralysis for other reasons, probably not going to want to use it. Apneic patients, I used to say, was a contraindication because, God, they're in CPAP. You can't have it. Well, if you don't have them spontaneously breathing, it's really just pressure control ventilation. And I will tell you that there is one unit I know of specifically, the trauma surgical unit at Royal Oak Beaumont. Anybody work there? Every one of their patients are on APRV. Even the ones that are brain dead waiting for organ procurement. And you know what? The patients who are there for the organ procurement, the patients who are on APRV, they have a far better salvage rate of lungs than anybody else. They just published a study recently about that you can get better quality lungs for retransplanting by using APRV. And if the lungs are good, I think a lot of the other organs probably are going to be good too, because they're well oxygenated. And that's the whole goal. This next one is one that I really am sensitive to. It's excessive minute ventilation demand. You're turning a good portion of ventilation, a good portion of that minute volume over to the patient's spontaneous breathing. If you've got a minute ventilation of 22, you probably are going to have a hard time with APRV. It might be better off to look at one of the other options, because that's a lot of work to put onto the patient. Okay. COPD, I used to say, with significant airflow obstruction, but you know what? I've seen it work in COPD patients too. So I've got to be conscious of that one. Neuromuscular defects, there's not a lot on, so throw that one in there too. The terms that we end up setting these patients on, two pressures, P high, P low. They're breathing spontaneously at the P high. When it's released, it goes down to the P low. And then there's two times. How much time am I spending at the P high, and how much time am I spending at the P low? Some ventilators, and I'll give you the example of the 840 because that's where my familiarity is. But in those cases, they don't have a T high, T low distinction. They use respiratory rate as an option. So I'll kind of explain that one. So if you're setting this person up from scratch, and you have them on, let's say, volume ventilation or pressure ventilation, conventional style, and you want to go to this, there's a couple of values that'll help you out. One, look at the plateau pressure that's being generated. Get an idea of what that is. Get an idea of what the mean airway pressure is, and get an idea of how much minute ventilation you're needing to get an acid-base status that is adequate for you. If I'm using the plateau pressure, that's a good place to start your P high. Get a plateau pressure. If you're using over 30, 35 centimeters of water, we're probably waited too long. Because really, if we're monitoring plateau pressure, and you're seeing plateau pressures get into the high 20s, we probably should be starting something different. Because that's probably the wrong time to say, well, just wait another 24 hours. No, we're already there. If you got a lung that is that stiff, you get some pretty significant problems. And alternatively, you could look at the mean airway pressure and add a couple. That's another option to end up having. So if your mean airway pressure is 18, set it at 20. P low is a real argument. And you're going to find people who have disagreements on this all the time. A couple of things. First of all, some places in the one of the trauma surgeons who has done the most work, or has been one of the most vocal advocates of it, is a guy by the name of Hibachi, who's out of Maryland Shock Trauma. He puts everybody at 0. There's other places that said let's do an optimal PEEP study and put them at that optimal PEEP level. I was always a chicken. I couldn't put them to 0 because I was always afraid of them de-recruiting. So I always put them on a little bit, 3 to 5. I was just a chicken. The key part is you have to learn how to read waveforms. How many people feel good about waveforms? See, this is where, the kids coming out of school now, they got it. Because we punish them, right? Us old folks, waveforms were PFTs and we slept through that lecture, right? Didn't pay attention to it. Now it makes a difference. We're going to watch that expiratory waveform. So that's P high, P low. T low is the key thing we want to monitor. The key thing we want to control. I want to keep that release time fixed. I don't want to screw around with that. And usually it's going to be less than 1 second, probably on the order of 0.6 towards that lower end. You never want to see a spontaneous trigger at that lower end. That's sayonara. T high then, or the respiratory rate, depending upon which ventilator you end up using, You want to have about, 5 or 6 seconds long. If I have a total cycle time, if I have a respiratory rate of 10 releases per minute, that's a total cycle time of 6 seconds. If I have my bottom port, my T low at 0.6, it means it's about 5.4 seconds at the T high. Okay? So those are the 4 parameters. P high, P low, T high, T low. Or may use the respiratory rate. If you're going straight to APRV, oh boy, you got a brave person there. Kind of using a similar kind of a thing. You'll probably have a P high somewhere around 25, 30. A P low somewhere either 0 or 10. And remember, well, I'll come back to that. T low, again, short, and T high, so I got somewhere around an 8 to 10 respiratory rate. If you're in the 840 world, 840 is kind of goofy because it doesn't have APRV as a mode. It has something called bilevel. How many folks use 840s, by the way? I'm not speaking to just a few of you. There is a setting when you go into the bilevel setting where you can lock one of 3 parameters. T high, T low, or the ratio between the two. Lock the T low. What you want to have is that no matter what I do to that respiratory rate, I never change the release time. That's key. Set your respiratory rate 8 to 10 breaths per minute. P high and P low to where you want them, and set your alarms. Here's the little locks I was talking about. You can see how it's locked there on T high. We can also do it the high to low ratio. My picture there. There it is, T low. That's where we want to lock. So now what I'm going to do is I'm going to adjust this to that 0.6 to 1 second. Very, very short release period. Set my P high and my P low appropriately, and I'm off to the races. So here's my spontaneous breaths at that upper level. When a release happens, it just releases it. Okay. Now here from a clinical standpoint is a little bit of a foggy issue. Okay. Because we're used to documenting a tidal volume. And we're used to documenting a spontaneous tidal volume and a mandatory tidal volume when we were in SIMV. Right? Remember those days? Well, the problem is here is I have 3 tidal volumes. I have a tidal volume that's spontaneous at that upper level. I don't have spontaneous breaths at the lower level because then I'm not in APRV. So that makes it easy. I got 1 spontaneous breath. But then I have a situation where I have a transition between the high level down to the low level, and I have a bulk movement of fresh gas coming in when it re-releases. Right? Because there's a spontaneous trigger that's synchronized to that transition, I have a tidal volume that is generated. Then there may be a point in time where I don't have a spontaneous effort synchronized with it, and I get a 3rd tidal volume. Oh boy. Okay. What determines these last 2 is the delta pressure, the difference between P high and P low. This is where it might make a difference whether I set my P low at 0, my P low at 2, my P low at 7. Because that's going to be a bigger delta pressure to see. Now granted, it's not a lot of times per minute, 8 to 10, maybe 12 times a minute, that you're doing this drop, but that will make a difference in minute ventilation. Okay? So you as a department have to figure out how the hell I want to chart on this thing. Because it's not as cut and dry as what we're used to in the past. Kind of like SIMV, but since how many people still use the SIMV? Yeah, it's kind of not getting less and less utilized. So I know the newer people coming out are going, what's SIMV? So minute ventilation that is generated on the part of the patient primarily comes from the spontaneous breaths. Ideally, because that's what you want. You want them to spontaneously breathe. You want to match ventilation perfusion as best you can. And that's done through spontaneous ventilation. Those release breaths will give you something, but it's usually about 1/3 of minute ventilation. Okay? And this is where us old folk have got to get into the habit of looking at the expiratory flow curve. Okay? What I want to do is I want to have that expiratory flow, which again is the downward followed back up, to be somewhere between 25 and 50% of peak flow. Oh my God, where's my calculator? So here's my peak flow. Let's say it's about 80 liters per minute. 25 to 50% would be somewhere between 20 and 40 liters per minute, and that's indeed where it is, about 30 liters per minute. Okay? So what I want to look for is I want to look at that expiratory flow curve and make sure it never comes back to baseline. Right? Now what do we teach you when you're volume ventilating and your expiratory flow curve doesn't come back to baseline? What do we call that? It's auto peep. Auto peep is evil, Rick. We can't do auto peep. Yeah, we can. Remember we learned it's the devil incarnate? It's horrible. You'll never do auto peep. Do auto peep. Because what auto peep is doing is it's re-recruiting alveoli. Guaranteed. Okay? But you got to watch the curve. And that's the hard part. Okay. So, who cares? These people have what? They have massive atelectasis. We need to re-recruit. One great way to do that is to not allow the gas to fully exhale. Okay. So here I have my ventilation that's going on. I have spontaneous ventilations going on up on top. You can see the spontaneous flow. I release. I don't come back to baseline. I leave some volume in there. Key part. Now what? I got them set up on it. Pearl number 2. Wait. That is the hardest part. I gotta get a blood gas. Why? You got a pulse ox? Cool. Got a capnograph? Cool. Why do you need a blood gas? This doesn't work. And this is what I tell my docs all the time. How long did it take you to get into ARDS? 5 minutes? Half hour? An hour? I don't think so. A couple days? How long is it going to take you to reverse that process? Certainly ain't going to be 30 minutes, guys. The longer you can wait, the better result you're going to see. Usually, 4 to 6 hours, you start to see some improvement. Okay? Pearl number 3, watch the spontaneous tidal volumes. You should see the spontaneous tidal volumes getting bigger. Now I'm going to be going on a limb here. I think the only way a tidal volume can get bigger spontaneously is if I'm recruiting alveoli. I may be wrong, but I think that's a sign of recruitment. Watch it. Watch the tidal volumes get bigger. As they're getting bigger, I know I'm doing things right. You have the ability to monitor minute ventilation. You have the ability to monitor pulse oximetry. And by God, even if we have it, we have capnometry. Is anybody using volumetric capnometry? Yeah, see, most of us got sold on capnometry, and I'll tell you what, volumetric capnometry is not your daddy's Buick. Okay? This is slick. They integrate the exhaled CO2 reading with tidal volume that's being delivered. So what you're doing is you're integrating those two values. And what you can end up doing is you can end up finding out how much of your tidal volume you are generating with each breath is going to dead space and how much of it is going to effective alveolar volume. That is huge. Because last time I checked, we don't really care what the tidal volume is. We care what the alveolar volume is in the process. Okay, so if you've never seen it, it's a great toy. Next time you're at one of the conferences, check it out. It's a pretty cool thing. First thing we want to do, get them off that high FiO2s. You got some oxygenation, you can get saturations are holding, go ahead and tweak that on down. Let's talk about some other weird things that ends up happening. And these are ones where I kind of scratch your head and say, gee, well, what am I doing wrong here? High respiratory rates. One of two things is either there. Either this is not the mode for them, and this is a patient who basically probably is one of those septic patients that have high alveolar minute ventilation needs, and probably is not going to be best served here. But what you can do is make sure we're on the right part of the pressure volume curve. When you have a patient in ARDS, you're down here. Large pressure changes for very small tidal volume, poor compliance. If I push them up the pressure volume curve by raising the P high, I might be putting them back into an optimal spot. So they're now spontaneously breathing and getting more volume for that same pressure change because now their lung is more compliant. Okay? Some people will argue using some pressure support. Yeah, it'll help. Just like any other patient who has spontaneous tidal volume is low, adding some pressure support will help. But you got to be careful if you're at that P high of 30, putting 10 of pressure support on is kind of stupid because you're going to a higher pressure. It just, to me, it doesn't make a logical sense. Okay. Plus, how you set pressure support is really a trick. Because pressure support, at least on the 840, is referenced to the P low. And I've seen people who have a P low of 5, a P high of 20, and they put 10 of pressure support on. It doesn't do anything. Because until it gets above that 20, the sum of the P low and the pressure support gets above 20, it's not delivering any pressure support. So, it's kind of a FYI. But push them up the curve. This is one that we discovered when Beaumont started doing a lot of patients with APRV. They were trauma patients. They had to take them back to the OR. Put them on the anesthesia machine. All the benefit you got just went out the window because they de-recruited because they didn't have the same thing. So what they ended up doing is either modifying their anesthesia units to doing inverse pressure control with long I times, or just use the ICU ventilator in the OR. Scavenge the exhaled gas and go ahead and ventilate it that way. Transport, same thing. I think I talked about that when I was talking about taking them up. You can't bag APRV, right? You got to transport with the ventilator. And most of the ventilators have battery backup. Most of the ventilators have mechanisms where you can hang a cylinder off the side, unplug them from the wall, plug them in there, poof, you're off and going. So you're transporting them on 100% oxygen for that short duration of time. That's not going to be as much of a problem. But certainly manual ventilation doesn't work well. So we got this patient stabilized. We're seeing their spontaneous tidal volumes go up. We're seeing their blood gases now. We take them blood gases, PO2's 200, yahoo, we succeeded. Over time, their chest x-ray has improved. Now I want to consider weaning them. We do a combination of reducing the P high while making the time spent at that P high longer. How many people have kids that are taking like geometry or something, or calculating the area of a parallelogram? God forbid, no. If I have a box, and the box is this big, I can calculate the area of that box, right? Height times length. Cool. If I make that box shorter but longer, same area. That area under the box we call mean airway pressure. What I have done is I have kept the mean airway pressure the same, but had the P high lower each time by lengthening. We call it drop and stretch. Drop the pressure down, make the time longer, the P high longer, or T high longer, excuse me. And if we're using the 840, the way I do that is I just turn down the respiratory rate. Did you guys ever notice on the 840 when you get down below a rate of 10, they go into decimals? 9.9, 9.8, 9.7. At first I thought the engineers were just, jacking me around. It's like, why would you put something on 9.4? Really? I'm going to put them on SIMV of 9.4. I don't think so. But this is where it actually comes into play and works quite well. When you get the P high down to around 5, that's CPAP of 5, guys. You're used to having patients on that all the time. Extubate them at that point. Okay? Or do a spontaneous breathing trial with some pressure support or however, tube compensation, whatever you're doing. So here I have my ventilation. I'm going to go ahead and do a drop and stretch. I go ahead and drop it, lengthen it. Drop and stretch. Okay? Pretty easy concept to be able to do. So let's talk about our case study. Back to our patient here. 22-year-old female, motor vehicle accident, chest wall injuries, internal abdominal injuries. What a mess, eh? Her blood gas is there. You end up seeing at 60% or PO2 of 51. PF ratio would be about 85. If she had bilateral bilateral whiteout on chest X-ray, no signs of cardiac failure, in an acute process, I would think would deceleration injury would fall into that category. We can call this ARDS, right? Is she a candidate? What do you guys think? Well, push your clicker. One or A. Let's get a consensus of the group. See if I made my case. Yes. I should be a salesman. If the mean airway pressure is set at 18, where would you set the P high? See what the group's consensus is here. About 20 is probably the best place to put it at. Okay. 30 minutes after, they had to get an ABG, didn't they? They had to get an ABG. Shows a PCO2 of 35. We'll assume a normal acid-base status or an acceptable acid-base status, and a PO2 of 60. What should you do now? I probably should have put a number 5 on there. SVN with albuterol at 0.5. I write questions for the NBRC, and I always put that in there as a little bit of a joke as one of the options, because I think it's it's dual in them now. Yeah, monitor the patient. PO2 of 60 is totally acceptable. We probably just didn't wait long enough. Okay, there's no reason that we have to be a knee jerk for every mechanism. You've heard of permissive hypercapnia, right? Letting the CO2 rise in some ventilatory strategies. There's almost an argument for permissive hypoxemia. 60's at the good part of the curve. We still got decent saturations that we can get with that. 24 hours later, her chest X-ray shows marked improvement. PO2 on 40% is 82. What should be done now? There it is. Okay. Let's see what you guys say. Now we can actually start beginning to drop and stretch here. You got a good FiO2, good PF ratio, or at least it's coming back up, and I can go ahead and begin the process of doing the weaning. Dropping the P high by 2, lengthening it by reducing or by increasing the T high in the process. So that's kind of the summary of it. Growing old is mandatory, growing up is optional. That is if you know me at all, that is definitely true. So where should you go from here? What are some of the things you should need to do? One is get a good understanding of what this mode is. This is one of the applications of mechanical ventilation that you don't want to find yourself at 3 a.m. on a Saturday, struggling like, what the hell do I do now? Got to get comfortable with it. Part of that is developing some clinical competencies. And one of the things I'm going to try to do is put together a clinical competency that we can have for departments to be able to utilize to say, this is how we check you off. Just like, I don't know about you guys, but I'm sure you do CPR every year, and I'm sure you do setting up something every year. You probably should be doing this, because if you don't use it that often, you're going to lose the skill set. Also, development of a protocol, and there's some really good ones out there that take into account pretty much all the things that you can end up going wrong on. Laminate that, put it by the ventilator, and you got a nice job aid to be able to refer to what end up doing in the process. Okay. And that is that. Let me do this.